Hi students, this is Jenny Villanova continuing with the second part of the integumentary system for NSG434 pediatrics. And this picks up on slide number 9 of the PowerPoint. Atopic dermatitis eczema is the discussion here. Atopic dermatitis is also known as AD. And we're going to continue the discussion of this as integumentary dysfunction, looking at the types of medications that can be used for it. So the biggest thing with AD is going to be the management of the atopic dermatitis. The big thing is going to be to relieve the itching because, of course, the more the child itches and scratches the lesions, the greater the potential for a secondary bacterial infection to occur. So we want to keep the skin hydrated, tepid baths. Sometimes oatmeal and an oatmeal bath can be very calming and helpful for the itching as well. Also, a systemic antihistamine may be recommended by the healthcare provider. And specifically, that would be diphenhydramine or Benadryl. You're familiar with this medication from level 1 pharmacology, but it would be to your benefit to open your pharmacology book to page 509 to 511 for diphenhydramine. This is a medication that could be a potential item on exams for NSG434. So be familiar with the side effects for Benadryl. And the biggest thing with Benadryl in the pediatric population is that it can go either way. It can act as a stimulant and cause the child to be almost of a hyperactive kind of nature. And on the other side of the coin, it can cause the drowsiness, the fatigue, just, the calming down, if you will, and they fall asleep. So, it depends on which way the Benadryl is going to affect the pediatric child. As it says here on the slide, children are more sensitive to the effects of diphenhydramine. They can have that nervousness, the irritability, the hyper types of activity that are opposite of the drowsiness that we usually expect in the adult population with diphenhydramine or Benadryl. Ooh. Well, so going and continuing on with integumentary dysfunction, part 2. I believe I may have started with the last slide of the part 1 PowerPoint, but this is the beginning of the part 2 PowerPoint, atopic dermatitis, and it has a continuation of therapeutic management. The biggest thing also with the pediatric population is to keep the nails cut short and trim, not only clip them short, but then file them so that there's no sharp edges. Topical steroids may be prescribed by the healthcare provider. However, they have potential local side effects such as striae, skin atrophy, pigment changes that may occur with use of topical steroids. There are some new topical immunodilators available by prescription that the healthcare provider may prefer to utilize. These are not in your farm book, but a prescription is required, and the side effects and potential adverse effects with these new topical modulators can cause some significant effects. So that's a concern there. And again, with the pediatric population, it's always a challenge with medications because sometimes we don't have the kinds of case studies and data that we have with the adult population. And let's see, going forward here, the next slide. There we go. The next slide talks about interprofessional care of atopic dermatitis, and it's really important that the family history of atopic dermatitis is explored. Again, as I mentioned, if there's a history of eczema, of asthma or any other kinds of allergies, this may predispose the child to atopic dermatitis. It's really important too to think in terms of dietary because there are certain diets that are of a hypoallergenic nature that may be very helpful to controlling the atopic dermatitis or eczema in the pediatric population. Dietitians are expert on this, so to involve the dietitian or nutritionist as a member of the interdisciplinary care team to develop a diet that can be helpful for the child. Additionally, emotional stress is increased during the acute phases when the child is having extra exacerbation of the eczema. It's usually, associated with maybe some emotional stress that may be occurring not only for the child but maybe within the entire family. Example could be that current coronavirus situation where children are having to be at home more, are having to adjust to homeschooling, are having to adjust to home activities and maybe not interacting as much with their friends. That's a huge change for the kids to adapt to, and so that could be a stressor for them that may cause their eczema to flare. The next thing I want to talk about is bacterial skin infections, specifically impetigo contagiosa. And this is a lesion, as you can see, that is of crustacean nature. And you see the yellow papules in here as well, too. And this is pretty crusted and dried. However, it is caused by the microorganism Staphylococcus the manifestations, as I mentioned, they are of a dried, heavy honey-colored crust, and that's where I mentioned about the yellowish color, and it is very itchy. It's very highly contagious, and kids with this are not permitted to attend school until they have received adequate treatment by their healthcare provider and have been on antibiotics. Page 953 in your textbook, the 6th edition, gives quite a bit of information about impetigo as well. And additionally, the management is going to be with a topical bactericidal ointment. Usually it's Bactroban or mupirocin or a triple antibiotic ointment that can be applied to those lesions. You don't necessarily have to cover them with dressing. The bottom line is keeping them open to air does facilitate drying, and that sooner that it does dry, it does heal much quicker. Oral or parental antibiotics are going to be prescribed for severe or extensive lesions, and penicillin is the first line of choice. And if the lesions are related to MRSA, then the child may be prescribed vancomycin and have a little stay in the hospital. But usually they can be treated orally with penicillin and with topical mupirocin or Bactroban applied. Bactroban is not in the pharmacology textbook, so you may have to utilize your other sources to freshen up on Bactroban. Fortunately, impetigo does tend to heal without scarring for the child, which is a benefit of the pediatric population. Another bacterial skin infection is cellulitis, and I'm sure you've seen this also in the adult population. There are 3 different microorganisms listed here that can cause the cellulitis: streptococci, staphylococci, and Haemophilus influenza. These are the 3 most common microorganisms causing cellulitis. And again, it's inflammation of the skin and subcutaneous tissue, as you can see, bright red here, and as you can see, the bright redness and swelling here. Intense redness, swelling, firm infiltration. Streaking can often be seen, but as I said, the most often manifestation is going to be swelling and bright redness of the skin. The child may also have a fever and malaise, which is generalized tiredness and weakness of the child. Management, what are we going to do for this kiddo? Well, we're going to give them oral or parental antibiotics. If they're oral antibiotics and it is not a severe type of cellulitis and causing fever and causing that malaise, they may be able to be treated at home. Otherwise, parental antibiotics, if those are prescribed, they will need to be hospitalized. The biggest thing is we want to rest this child and immobilize of the affected areas in the child. And usually because of the fact that they are experiencing fatigue and tiredness, that helps to be able to get them to rest and to immobilize much more effectively. Hospitalization may be required, but not all the time. It just depends upon the severity of the cellulitis and what the course of treatment is that the healthcare provider has decided upon. So if the symptoms become symptomatic, then the child may be hospitalized. Another type of integumentary dysfunction is pediculosis capitis, commonly known as lice, and this is caused by the pediculosis humanus capititis, and essentially they are these tiny little bitty white flecks that we see in the hair. In your textbook on page 953 to page 954 of the 6th edition, the pediatric textbook is a further discussion about lice, but essentially the organism is of a blood-sucking nature. So when the egg is laid right next to the hair shaft, close to the skin, that allows the organism then to be able to suck the blood right from the skin and then of course grow and develop. So the manifestations, what are we going to see in this child? We're going to see itching, and itching is usually along the occipital area or the bottom of the hairline in the back of the neck, behind the ears and nape of the neck. So it's usually in those back areas where we're going to find the location for the lice to be embedded. The biggest thing is that it does cause a lot of embarrassment for the child and for the parent. Unfortunately, there is social stigmata with it that, it's because they've been, their environment is not clean, the child has not been utilizing good hygiene, and actually none of that is really founded in research or in evidence, but the bottom line is that is the perspective of society, and unfortunately, a lot of times, especially in girls, parents may elect to go ahead and have their hair cut so that it's much shorter, and they can get in there and comb out the nits close to the hairline. Obviously, that calls attention to the child, which only feeds into the embarrassment and the whole self-image perspective that goes. So we really want to emphasize with the child and the parent that, anyone and everyone can get lice. It doesn't have any, discrimination for age, for socioeconomic level, for cleanliness, for home environment, for practices. It just is a common, unfortunate integumentary dysfunction that occurs amongst the pediatric population. And I'm sure most of you can remember back to your school years, and either you yourself had lice or knew of a classmate that had lice, and you all were being cautious in your classroom. As I said, the eggs are implanted close to the skin where they have a nice warm environment to grow and develop. And then the nits are tiny whitish oval specks that adhere to the hair shaft. And the next slide here has some pictures of the nits, and as you can see, the little tiny white specks, and they adhere to the hair shaft. They also can occur in the eyebrows. I've seen them in the eyelashes, and I've even seen them in pubic hair with adolescents as well too. But the bottom line is, they can occur anywhere on the child's body that there is, hair that will be conducive for growth. So therapeutic management, what do? Application of a pediculocide is necessary, and the most common one that's frequently utilized by parents is or caregivers is NICS, permethrin, 1% cream rinse. And how this works is it's applied one time, the first time as a cream rinse, for after shampooing the hair, and then it recurs. We give a second treatment in 7 to 10 days after the first treatment. So it's a two-step treatment. Day one, the cream is applied and rinsed, and then the second time, 7 to 10 days later.